thanks everybody. Welcome to the third webinar in the Simulation Guided Trial Design series. And I'm very happy to hand this over to Elias to present on the simulation guided design and the using advanced CRM features.
Thank you, Tom, and thank you everyone for being here today. Apologies beforehand for not having my camera on. My internet connection is a bit unstable today, so I think it's better I leave it off. As Tom already mentioned in his introduction, today we'll look at designing a more advanced CRM dose escalation study. And I should mention that the study we're going to design together today, in fact, is fictitious, but it uses learnings of actual trials we have designed at Berry Consultants. So to set the scene, let's imagine we're in a situation where we have, where we want to design a first-in-human study of a novel compound. Let's assume we have animal data and first PK, PD data available. The company that wants to design this trial is preparing for an IND submission, and for sake of argument, and you will see later this influences some of the design choices we're making. Let's assume that this is not a small biotech, so we're not interested in showing phase 1 proof of concept as soon as possible, but we would eventually be interested in taking this compound all the way to registration. So one thing that this means in this particular situation is that the company designing this trial would want to go to a seamless phase 2, phase 3 right after this study, if possible. So one of the things we're trying to do in this trial is not just learn about the MTD, as we did last week, but also look at clinical activity and maybe find something like an optimal dose, whatever that means. And we want to do that as soon as possible and seamlessly in this dose escalation trial. So let's assume we're in a situation where we have a DLT observation period of 14 days. We have a targeted toxicity level of 25% with acceptable limits from 15% to 35%. One of the things we want to have is, I'm just going to call this cohort size now, a cohort size of 3, although we're not going to use cohorts in this trial. We're going to use open enrollment, but I'll explain that in a moment. So what that means is we want to have at most 3 trial participants simultaneously in the DLT period at a new dose level or at the current MTD estimate. And the reason we want to have this, so there's some historical background in the trials that we were designing. A lot of the people on the team had only done 3+3 before, and this was their first CRM design, so of the clinical folks, not of the biostatisticians. So they would not feel comfortable with anything else, with any other number than 3. And I think that's a pretty reasonable thing to do. The dose range we're going to investigate goes from 100 milligrams to 350 milligrams in 25 milligram steps. And one of the aims of this study, before the possible phase 2, phase 3 that they want to do after that, is to identify a correct optimal dose. Again, whatever that means, but it should be in a range of plus minus 25 milligrams. So whatever dose we're recommending going out of this trial, they would want it to be the correct optimal dose plus minus 25 milligrams. So that's sort of the precision that they're requiring. And then they would take probably this arm plus 25 milligrams and then minus 25 milligrams into the phase 2 part. Another thing that we're doing here is we're a priori assuming that the therapeutic effect might start around 175 milligrams. So this is, of course, just based on very early data that the company has, and we need to verify this in the trial, but this is going to influence, again, some design decisions, as you will see later. So we're not just looking at the toxicity endpoint, we're also looking at an efficacy endpoint. And for this efficacy endpoint, they're targeting at least 20% response rate. So this is a binary efficacy response rate. And in the actual trial, this was going to be a 4-week endpoint based on some PK/PD model. But one thing I should mention here is FACTS currently does not allow you to simulate different observation times for the toxicity endpoint and for the efficacy endpoint. So this is one of the sort of simplifications that we need to do in this trial, that we assume that this efficacy endpoint is also available after 14 days and not after 4 weeks, as it would be in the real trial. They want to have a maximum sample size to determine the MTD. So that's sort of a phase 1 part of this trial of 60, but we will see later that in most of the cases, we're not going to need all of this 60, but that's the maximum they would be willing to have in this trial. And then we want to spend up to another 50 trial participants to determine the dose response. Again, we're going to see that we won't always need this 50, but sort of those are their maximum sample sizes. So let me do one thing and jump from this to FACTS. So I've already entered this design in FACTS and I've simulated this in FACTS, but I want to show you how we would set all of these things in FACTS. So there's many other design decisions we're going to make later, and I'm going to show you each of those in FACTS, but let's start with this one so we don't have to remember too many things at the same time. So in the FACTS CRM engine, the landing page is sort of the study info tab. And you will see I've selected include efficacy here because I want to simulate both the toxicity endpoint and an efficacy endpoint. I've selected open enrollment. We'll talk about it in a moment. The maximum number of subjects is 90 plus 20. This is 110. This is the 60 plus 50. That's maybe a bit difficult to explain now why there's 90 and 20 here. Let's again revisit this later, but just for the moment, you can see that this is 90 plus 20, so 110. We have time until final results. This is the outcome observation time. This is set to 2 weeks. So this is the 14 days that we've seen previously. And then let's jump to the toxicity tab, where you can specify your target toxicity and then the sort of the acceptable limits around that. And you can see I've specified the target to be 25% in line of what we mentioned before. And then the acceptable limits are 15% to 35%. So this is sort of the band around the target. So that's the target band. Anything below that is considered underdosing, and everything above that is considered overdosing. And then FACTS also has this notion of completely unacceptable toxicity. But yeah, basically it means everything that's above 35% is unacceptable. Okay, here in study arms, you can see I've entered all of the dose strengths that we want to investigate. We wanted to have 100 milligrams as the lowest dose and then go up to 350 milligrams in 25 milligram steps. So you can see this is what I've set up here. And for efficacy, you might remember we said I want to have at least 20%. So you can see that this is my target. I want to have at least 20%. Okay, let's go back to this. Let's now talk about open enrollment. So I don't know if this is something Tom already touched upon last week, but in cohort enrollment, what we're usually doing is we're assigning a fixed number of trial participants to a dose. We sort of wait until mostly that's 3 patients, until 3 patients become available, and we start treating them. We treat them for a certain time. We observe them for a certain while. And after that, we see how many of those had a dose-limiting toxicity. And then based on that, the algorithm tells us if we should stay at this dose level, if we should escalate, if we should de-escalate, or if we're finished, sort of thing. In open enrollment, we are doing it slightly differently. So we're not waiting until, say, 3 patients have become available and then we treat them all at the same time. And then while those patients are in their outcome observation period time, we don't enroll any other patients in the trial. But what we do is we actually enroll the patients as they become available. So that means some of them might be treated a bit faster. And that also means that while there's, say, 3 patients at the top dose, we have another patient enrolled in the trial, and then we need to decide what happens with this patient. So this, of course, requires additional rules and risk management, but it can provide many advantages. This is you saw this before. I specified this by checking the checkbox use open enrollment. One thing I'd like to mention here before we're jumping into actual simulation results and discussing more of the design elements is what was the value of simulations here in designing this trial and in engaging with the clinical team and with other stakeholders. Especially with these CRM designs, they're quite complicated. They're quite sensitive to the prior. You've specified there's a lot of moving parts. So it is difficult to understand the behavior of the design. It's even difficult for the person who's designing the trial, and it's even more difficult for people who have no experience with CRM or who might not even be biostatisticians in the first place. So really the value of simulations here in the design process was it allows you to understand how the design behaves, and we'll see that in the course of this presentation. It then allows you to communicate the design and the behavior to the team. And then as soon as they understand what the design and what the trial is about and how it's behaving, then they can give you the appropriate feedback as to whether you need to change things and whether this is the right way to go in this trial and whether that answers their research questions. And then when you get this feedback, it allows you then to tweak and update the design and see if the changes that you've made now lead to the design behaving in a way that is required. And also if you made the design more complex, if this complexity is justified by improved design behavior or by improved operating characteristics. So really this is this iterative process of simulations where in the end you converge to a good design that satisfies stakeholder requirements. And you can only converge to this design if the stakeholders and you understand the design. And that's where the value of simulations is here. And then, of course, in the end, once you've converged to a good design, what you can do is you can check its robustness under a set of assumptions and see whether it behaves the way you want to behave, also in extreme cases that maybe are unlikely in reality, but could happen. Let me show you a movie of how this trial could have played out. So you don't yet, I haven't yet told you all the design elements, and I haven't shown you, of course, how to specify them in fact, because we haven't talked about them. But before I do that, let me show you how we would want this design to behave. And then let's sort of retrospectively engineer how we need to set the design to achieve this behavior. So remember, we wanted to start with 100 milligrams. That's always shown here on the y-axis of these 4 plots. On the y-axis, you always have the dose. And then these 4 plots differ with respect to what's on the x-axis. The most important plot here is the one on the very left, where we're going to see a timeline of new patients being enrolled in the trial and what doses these patients are being assigned to. And then, once their outcome observation period is over, whether they experience the dose-limiting toxicity or not, and whether they responded or not. The second plot from the left is going to show the current model fit of the dose-toxicity relationship. So you can see in black, this is sort of the median, and then the gray shaded area is the credible interval. One thing you can see here is while we're at the beginning of this trial, we have a very vague prior. Then the third plot is only to show what we currently think about the doses in terms of whether we think whether we're sufficiently sure they're safe or not. So in the beginning, we know nothing. So they're all experimental. They're all red. I mean, we start with 100 milligrams, but we don't yet know whether this is safe or not. And then the plot on the very right shows the dose efficacy, the estimated dose efficacy relationship. And again, here you can see that this is an extremely vague prior. So let's go through this. It's going to play as a movie, and I'm sort of going to narrate through this as different things are happening. So the first patient arrives. We assign this patient to 100 milligrams. By the time the second patient arrives, the first one already had their outcomes observed. So they're a green dot. They didn't have a toxicity and no efficacy as well. And as a result of that, the NTD estimate changed. Then while the second and the third patient are still in their outcome observation period, more patients arrive, but we can't yet add them to the trial because we still need to wait for this third patient on 100 milligrams to complete. At some point, this patient has completed, no DLTs, so we're happy escalating to 150 milligrams. So that's where we're assigning the next 3 patients. By the time the next patient arrives, they all had their outcomes observed. None of them had a toxicity, so we're happy to escalate to 200 milligrams. Again, we're assigning 3 patients there. By the time the fourth patient arrives here, the first patient already had their outcomes observed. So you will see here that we have 4 patients on 200 milligrams. We'll talk about that later. That's front filling. There was again no toxicity, so we're happy escalating to 250 milligrams. There we see the first toxicity. So the model immediately makes us de-escalate again, a second toxicity. So we're back down to 200 milligrams. Then a couple of other patients don't have a toxicity. So the model now thinks 225 milligrams might be the MTD. More patients there, another patient with a toxicity on 225 milligrams, but still the model thinks that's the current MTD. And now you will see something interesting. The star that represents the current NTD estimate is still at 225 milligrams, but we've started assigning patients at 200 milligrams. So all the patients we're now assigning are at 200 milligrams, even though we think the current NTD is 225 milligrams. And that's because we've reached a point where we are sufficiently sure that we found the MTD, and the MTD is 225. And what we want to now do is start assigning patients to the MED. So the dose, the lowest dose that we think guarantees us this 20% response rate that we talked about before, and that the model and estimate for that is 200 milligrams. So that's why we're assigning a bunch of patients here at 200 milligrams. And what you will see is that there's a lot of patients being assigned to 200 milligrams, but eventually it's going to stop. And I'm just going to skip this. So there were more patients assigned to 200 milligrams, but at some point we decided, okay, we're going to stop the trial now. So this was 45 patients in total in this trial. And just to recap, we started at 100, we escalated to 150, then we escalated to 200, then we escalated to 250. That's when we started seeing toxicities. Then we went down, and then eventually we stayed at 200 and assigned a lot of patients at 200. And if you don't yet understand why the trial behaves this way, that's completely normal because we haven't talked about all the design elements. I only wanted to show you this movie as sort of a teaser for how we want this design to behave. And this is how we would want this design to behave. Escalate until the model is somewhat sure that it has found the MTD, and then stop assigning to the MTD and instead assign to the dose that we think is the minimum efficacious dose. Okay, let's talk about the prior and the statistical model being used here. So this is, of course, a 2-parameter Bayesian logistic regression model, where, as you've seen before, we started with reasonably uninformative priors, and I will show you in a moment, in fact, exactly what the priors were. And of course, as you know, the parameters are going to be re-estimated after every patient with complete DLT information. And then in the end, the MTD that we choose, so all of the dose escalation algorithms, they have some way of choosing the MTD estimate in the end. Either they do some sort of isotonic regression and then choose the estimate that's closest to the target, or they choose the estimate that's below but closest to the target. And in this case here, we're choosing the dose for which the model estimated probability of a DLT is closest to the target toxicity rate, 25%. So let's go into facts. In the wait, this is the wrong one. This is the right one. Sorry, it's a bit confusing. Sorry. Here in facts, in the design tab, you have some way of specifying the x hat. So just to mention here, we chose the median dose as the reference, and the x hats are the log of dose divided by reference dose. So this results in these x hats. And then what you do is you specify priors, both for the dose toxicity and for the dose efficacy relationship. Here for the dose toxicity, you can see that we've specified these priors, which are fairly standard and fairly uninformative. And this results in this plot, which is basically the same plot we've seen before, just upside down and mirrored. And you can see that we didn't specify prior pseudo subjects here. Sometimes what you do is when you specify your prior and then you run the simulations and you find that the model doesn't fully behave how you want it to behave, you could specify prior pseudo subjects here just to tweak the behavior a little bit, but it wasn't necessary in this case. For efficacy, you can see that we've specified these priors. And again, this is a fairly vague and fairly uninformative. Okay. Let's move on to some other rules. So one other thing that we wanted to do is we wanted to start at the lowest dose. So this was 100 milligrams. And then we want the CRM to behave in such a way that it always skips one dose level. So increments of 50 milligrams are okay. So we saw this before in this movie that we jumped from 100 milligrams to 150 milligrams. And another thing is that we always require data on 3 patients before we escalate. The way you set this, in fact, is you go to the design allocation rule tab, and then here you have initial dose, so you can specify what the initial dose is. In our case, that's 100 milligrams. And then here you have these rules that govern how much you escalate and how many patients you need on a dose before you're happy to escalate. So we want to have 3 patients on a dose before we escalate. Facts calls this being cleared. So the concept of a cleared dose is once we have data of this many subjects available on this dose, we consider the dose cleared. And then here you can specify how you're going to increment, whether you're just going to increment by fixed steps, or whether you're going to, you can also do it by ratio, so you can always increase by 50%. But in this case, it was very simple. I just specified a value of 2, meaning I always increase by 2 dose levels. So it's the sort of 0, 1, and 2. So jump over 1 of the dose levels. Okay. One of the things you saw here in open enrollment is that these patients arrived separately. They didn't arrive as cohorts, but they arrived separately. And there's certain rules that you need to set that govern how this open enrollment works. And there's 3 queue lengths that we have, in fact, to really tweak the behavior to exactly how you want it to be. And that's how many patients do you allow without final results if a dose is uncleared. That's 3. You might think that this number is always the same as the one we've said before about cleared doses, but that's not necessarily the case. Imagine that we want to have 4 patients to clear a dose, but we always only allow 2 patients to be on a dose before they have their results. Then what would happen is we would assign 2 patients to 100 milligrams. We would wait until they have their results, and we would assign 2 more at 100. Then again, we would wait, and only then we would escalate. So how many patients need to be on a dose to clear it is not necessarily the same as how many patients you allow to have on a dose without final results if the dose is uncleared. Tom, I see you came off the news.
Yeah, Elias. So somebody's asked if you can enlarge the facts window to make it a little more readable. They're having trouble seeing the options clearly. Unfortunately, just dragging the window isn't going to increase the size.
Exactly.
Yeah, apart from changing the resolution of your screen, I don't know what you can do.
I mean, the only other thing that I can do is, since this is running in a virtual machine, I can just resize the virtual machine. I don't know if that made it better. Did that make it better?
Yeah, that looked better to me. Yes. So, yep. And I've had a thank you for that. So,
yeah, great. Thanks for
thanks a lot.
Yes. Okay. So let's get back to these three Q concepts. So that's how many patients we allow to be, for example, at these uncleared doses at the same time. But then in the process of the dose escalation algorithm, maybe at some point we de-escalate it, and then we are not. So maybe we're at a dose that is already cleared. And then the question is, how many patients do we allow there? And we could tweak these numbers if we want a different behavior. So the 6 here, this is maximum subjects without final results if doses cleared and below NTD. And you might wonder, when would we ever assign below NTD? And that's, for example, the case, as we've seen before, if we think, for example, NTD is 225 milligrams, but MED is 200 milligrams, and now we want to assign to the MED. And there we might be happy assigning more patients at the same time. And this also matters when we're doing backfill, which we will see in a moment. So one of the things that we saw here, I mean, maybe it was a bit fast, so maybe we did not actually see this, but remember there was this one case where we had already escalated up to 250 milligrams, and then we were sort of bouncing between 225, 200, 225. And here, there was one instance, maybe I'll also enlarge this just so it's a bit better visible. So there was this, So there was this one case where we believed that 225 was the MTD. So we had assigned 3 patients there. But we have this queue length of we don't want more than 3 patients at the same time at the dose where we currently think it's the MTD. And then what happens if a new patient arrives? And again, this patient could just be lost, not lost, but sort of put on a waiting list to receive a treatment. But what we did here was we backfilled this patient to 200 milligrams. And we did that because we had previously investigated 200 milligrams. And we thought 200 milligrams is sufficiently safe. So while we're waiting for the results of these 3 patients on 225 milligrams, we're happy treating this patient at 200 milligrams. And of course, since we're doing a CRM and since we're estimating the dose toxicity and the dose efficacy relationship, every single data point that we have counts towards the final model. So the information that we're going to get from this patient is going to be helpful for us in estimating the dose toxicity and dose efficacy relationship. So let's go back here. So what were the backfill rules that we specified here? We did not want backfill to happen below 175 milligrams. And if you remember, that's where we expected to see the therapeutic effect to start. So don't backfill at doses where we think they don't have clinical activity there, because that might be unethical. Another thing is we would not want to jump more than 1 dose level below the current escalation dose. So here we were assigning at 225 milligrams. So we wouldn't want to backfill to anything below 200 milligrams. That's just a choice. Sometimes you're happy backfilling below, but sometimes you're not. Then there's some sort of a limit on how many patients we would want to backfill to a given dose, and what number of total patients shouldn't be exceeded through backfill. So let's go back to facts again. So here in the design tab, so no, let's start this way. So in the study tab, there's this checkbox over here that says allow backfill that you need to tick to allow backfill. And then in design, you have this tab appearing, which is backfill allocation. And here in backfill allocation, you can set exactly these things that I just mentioned. So how many patients in total should be on a dose if you're backfilling? How many patients by backfill? How many maximum patients can you backfill to a dose? So this number is the number of backfilled patients plus the number of regularly assigned patients that backfill cannot exceed. And that's just a number that pure backfill patients to a dose cannot exceed. Here you specify how many levels below the current escalation dose you want to allow backfill to, and then sort of what's the hard cap on below this dose we're not backfilling. Here is another checkbox which says allow front fill, brackets backfill to current dose. What is front fill? Front fill is the same as backfilling conceptually. So we're in a situation where we're waiting for results to come in, and then we're deciding what happens with this new patient that becomes available. Do we treat them or do we put them on the waiting list? The only difference here is there's certain situations where we're happy to backfill to the current escalation dose as opposed to a dose below that. So if you look at this particular example here, again, you remember we had escalated to 200 milligrams, and you see 4 dots here. The 4th patient is the one that was just newly assigned to 200 milligrams. That's something you would never see in a BOIN or 3+3 or any other cohort-based dose escalation design that works with fixed cohort sizes of 3. Because what happened here is, by the time this 4th patient was enrolled to the trial, we had already observed the data from the 1st patient that had previously been assigned to 200 milligrams. And they didn't have a toxicity. So in other words, this 4th patient that we're assigning to 200 milligrams makes now 3 patients at 200 milligrams that don't have outcomes observed. So we're sort of shifting from, okay, let's assign 3 patients at the same time to 200 milligrams, and now we're waiting for their results. And conceptually, this means we are happy having 3 patients at risk at the same time. But what happens with open enrollment is by the time this patient arrives, there's only 2 patients at risk anymore. So you're happy putting a 3rd patient at risk. That's what's happening here. And this is front fill. And this is what we allowed with this checkbox. Another thing we want to have in this trial is overdose control. So this is EVOC, escalation overdose control. And what this conceptually does is we temporarily exclude doses from allocation where, based on the current model of the dose toxicity relationship, we think that the probability is too high that they have unacceptable toxicity. So the rules that we set here is we're only assigning patients to any given dose if, based on the current model, the probability that the toxicity on this dose is larger than 35%. This needs to be smaller than 50%. And the probability that the toxicity on this dose is above 50% needs to be smaller than 20%. And only if both of these hold, we're happy assigning patients to a given dose. And you see this in action at this particular stage of the trial, where we had escalated to 250 milligrams. And then the first patient, so we assigned 3 patients to 250 milligrams. And then by the time we observed the first outcome, we saw this was a toxicity. So we jumped back down to 225 milligrams. And then by the time the next patient was enrolled in the trial, we had the result back from the second patient on 250 milligrams, which was also toxicity. So at this point in time, we thought 225 is not safe for allocation anymore. So that's why we dropped back down to 200 milligrams. And I don't know if you remember this. Let's just go back to the graph of how this looked in the end. So you can see here at some point, after all of these 3 remaining patients didn't have a toxicity anymore, we were happy escalating again to 225 milligrams. So going back to this graph, we will then see that all these 3 pending patients don't have toxicities, and then we will escalate to 225 milligrams again. This is something that you also usually don't do with the overdose control in things like BOIN or MTPI2, because the sort of the overdose control that you have in these designs is usually absolute. So at some point you decide to exclude a certain dose from assignment, and then you never assign to this again, regardless of what you learn in the future. But what happens here is they're only temporarily excluded. Okay, let's look at 2 more things. And I know this is a lot, but that's the point of this webinar, to explain sort of many of the advanced features that we have in CRM. And I'm not even touching 50% of what is there. So there's really a wealth of features and design options you have in CRM. But 2 other things I was using here in this design is I had early stopping rules for the phase 1 part, which is the finding the MTD part, and early stopping rules for the what I call the phase 2A part, which was the finding the MED part. So for the phase 1 part, maybe let's show this immediately in facts. So in the design stopping criteria tab, you have rules where you can exactly specify when the trial should stop. And on the left-hand side here, all of this yellow stuff is sort of the MTD searching part. And then the green stuff here is the MED searching part. So one of the things that we did was we have this concept of a near dose, and that is every dose in a range of plus minus 25 milligrams. So for the purposes of, for example, deciding to stop if the number of subjects on the current NTD estimate is 9, what we're doing is we're not just looking at on this one particular dose is the number of patients 9, but we're looking in a plus minus 25 milligram window if the number of subjects is 9. So we can have a look at this this simulated trajectory here on the left-hand side. At some point here, this new patient, this blue dot, was the first patient that was assigned in the phase 2A part. So this patient marks the end in our simulation of the MTD part, and this is now the start of the MED part. And we can see that we've accepted 225 milligrams as the MTD, but there's not 9 patients here. There's only 1, 2, 3, 4, 5 patients here. But the number of patients here, plus the number of patients on 250 milligrams and the number of patients on 200, brings this number to larger than 9. So this is satisfied. So you might wonder, why didn't we stop with this already before? Because looking at 200 milligrams, there's 6 patients there. So there was in total 14 patients near 225 milligrams. Why did we only stop here and not already earlier? Well, there's another rule here that we specified, which is that we want the probability of this dose being actually near to the true MTD greater than 60%. So this takes into account the uncertainty that we have in our posterior estimate about whether the current MTD estimate is actually the true MTD or not. And only if we exceed a certain number here are we really happy to stop the MTD search. One other thing here is that the minimum number of toxicities can be specified. So that's 2. That basically means we will not stop the MTD search if we've not at least seen 2 toxicities. And another thing here is we can have a hard cap on the maximum number of subjects used to determine the MTD, and that's the 60 that I mentioned in the very beginning of this presentation. Of course, this is just for the purposes of the simulation of showing how this algorithm behaves. In practice, the DMC or SRC or sponsor may always say, no, we will continue assignment to 225 milligrams. But yeah, that's, outside of the scope of this simulation. And then the other thing that we have is we have rules for ending the trial, sort of ending the final trial after sort of the phase 2 part of this trial. And that's specified here. So we specify that the maximum subjects on the estimated MED is 25. And again, we want to have a certain, we want to be sufficiently sure that we've actually found the true MED. And that's when we'll stop. And that's why here it took, here we assigned patients to 200 milligrams until the total number of patients here was 25. And then we were happy to stop the trial because we were sufficiently sure that 200 is actually the MED. So when you're designing this trial, that's a lot. There's a lot of moving parts here. The stopping criteria, they interact with the priors. It interacts with the allocation rules. It interacts with what you've set as your toxicity targets, as your efficacy targets. All of these things interact. There's lots of moving parts, and it's not easy to design a trial like this. So what I personally like to do is I like to walk through these individual simulations. So the first thing I will do is here you will see, here you can see I already simulated 10,000 of these in several different scenarios that I will touch on in a second. But in the beginning, it's enough if you do 10 or 20 of different scenarios. So then what you can do is, this is really invaluable for making sure that this design behaves how you want it to design, is you can go to explore results and then first sim allocation history. And then you have exactly these timeline plots that I showed you in the movie. You can walk through them step by step. So the one that I showed you is I showed you the 26th simulation. And then what I like to do is I like to click space interims equally. This just means that the subjects arriving here on the x-axis, they're in equal spaces, and it doesn't go by actual time of when they were enrolled. And yeah, and then so you can really walk through this. So I'm using just my keyboard, my up and down arrows, and you can walk through this and you can really see how this plays out. So here we can see, yes, we had assigned 3 patients to 100 milligrams. Then there were a few more patients arriving that we couldn't put on a dose. And then at some point you can see, well, we had 3 results in 100 milligrams. So this little triangle here appears, which tells us that the simulation, the model at this point in the simulation now thinks 100 milligrams is a clear dose, is safe enough. And then we're escalating. And then what you can go is you can really walk through this and you can see whether this behaves in the way you want this to behave. Here you can see this patient got a star, which means this was a front fill patient, as I mentioned previously. And you can also see how the accumulating data translates into model estimates of MTD and MED. Those are the red triangle and the green triangle. So you can really go through this and you can really understand in depth what is happening and why it's assigning patients to the doses it's assigning patients. I know when I showed you the movie in the beginning of the simulation, probably it was way too fast for all of you to grasp what really happened. But when you're walking through this step by step, you can actually understand what is going on. And you can also explain this to other people. Clinicians, they might not understand if you put a model there and you specify priors and you write a lot of formulae. They don't understand what that does. But if you show them this and you show them, look, we escalated to 250 milligrams, but then we saw toxicities, so we didn't think this dose is safe anymore, so we're assigning patients at lower doses, they understand that. And they can have an opinion on that. They can tell you, well, we wouldn't have done that, or we would have de-escalated even further, or things like that. And then this is the feedback that you need to design the trial in such a way that it answers the research questions that they have, and that it behaves in the way that they would want it to behave, or a DMC would then make decisions when they're seeing accumulating data. So this is really invaluable as you're designing this trial. So I have a little list compiled here of things that I like to look out for and how to respond to them. So when you're looking at these individual simulations, I just showed you one scenario, but let's maybe go back and let's maybe show you a scenario where all of them where all of the doses are toxic. So in a situation, for example, where all of them are toxic, what you might see is something like this. We're starting at 100 milligrams. We're assigning 3 patients, and then we see one toxicity out of these 3. What would you want to do in this case? Well, following what a standard 3+3 would do is you would want to assign 3 more patients, for example. So that's what you do. You stay at 100 milligrams and you assign more patients. But before you've even assigned 6 patients, the first of these potentially 3 extra patients you would have been willing to assign to this dose already had a DLT. So you didn't even need to assign 6 patients. So it was enough to assign 5 patients, and then you were happy to stop and declare that they're all toxic. But so it's things like these. It's really going through these movies under different assumptions of what the true dose toxicity or true dose efficacy relationship is, that lets you see if the design behaves in the way you want it to behave. So yeah, going back to these things. So what if, for example, you assigned the first 3 patients, and then it suggested that you escalate after these 3 patients, even if all 3 of them had a dose-limiting toxicity? Or what if you assigned 6 patients to the first dose and none of them had a toxicity, yet the model tells you, well, do not escalate, stay at this dose? Well, if that's the case, then you know you need to go back to your prior and you need to tweak the prior, or you need to include pseudo subjects, or you need to look at your overdose control rules. What if, for example, you were at some point in the simulated trial, say at patient number 31, and you're now relatively sure that 225 milligrams is the MTD, but you keep assigning patients there. The 31st per patient, 32nd patient, the 33rd patient. Let's assume we put another 30 patients at 225 milligrams, because we allow up to 60 patients in this trial. But nothing happens anymore. The estimated MTD doesn't change. We've just assigned 30 more patients to the estimated MTD. And we certainly don't want that. If we're sufficiently sure at some point that 225 milligrams is the MTD, then let's just stop. Let's not assign more patients there. So if that happens, if you see that happening in your simulations, then you know you have to tweak the stopping rules. What if you have simulated fast recruitment, and then you have lots of lost subjects? And by lost subjects, I mean subjects that we can't treat at any of the dose levels. Or we have way too many backfilled subjects, potentially at doses that are sub-therapeutic. Well, if you see this in your simulations, then you don't know you need to tweak the backfill rules. What if say you've cleared 200 milligrams and now we're escalating to 250 milligrams, but you're assigning 10 patients there at this untested dose? Well, then you know you need to tweak your queue lengths that we were talking about in the very beginning, which can be found here, which is sort of the risk. This is our risk management in open enrollment. And another thing so there's many things that could happen, but one other thing that happens quite frequently in practice, and where it's good to have sort of a fix for this. What if you're at some point in your trial and you're jumping between 225 milligrams and 250? So now you think 225 milligrams is the MTD, so you assign patients there, then you see the results. Now you're happy to go to 250. Now you assign patients there. Now you get back the results. One of them was a toxicity. Now you're like, no, maybe it's 225 milligrams. So you go back to 225 milligrams, and you just jump back and forth these 2 doses. Well, if you're jumping back and forth between these 2 doses, I mean, if we're in a situation where we know that plus minus 25 milligrams is within the precision that we're happy having for this trial. If we go out of this trial and we declare 225 milligrams as the MTD, but in fact 250 is the MTD, then we might be fine with that if this is sort of our required precision of this trial. I mean, we're already very close. If that's the case, then what you can do is you can go to the stopping rules and you can add this concept of near doses, such as plus minus 25 milligrams, what we did here in design stopping criteria. And then what this leads to is exactly what we've seen happening here. Sorry, where is it? Here at the end, where we were happy, here in the middle at around patient 25, where we were happy ending the search for the MTD because we've got sufficient data on 200 and 250, and then we're happy declaring 225 as the MTD. Okay, one other thing where I'm afraid I won't have enough time now to go over is, but what I wanted to show you is how can you now compare such a CRM to other dose escalation designs, say a Boyne or a 3+3 or an MTPI. And I won't show you the results of this. I will just go over this conceptually, how you could set up simulations to compare these. So what I have is, of course, I have this this phase 1, phase 2A CRM, where at some point I'm switching from the hunt from the MTD to the hunt from the MED. And comparing this to, say, a 3+3 or a Boyne that is happy stopping once it thinks it found the MTD wouldn't be a fair comparison. So what you can do is you can set a second facts file, so I have this facts file where I included efficacy. And then what I did is I duplicated this file and created another file where I did not include efficacy. So I reduced the number of subjects to this 60 that I allowed in the phase 1, phase 2A for the MTD search. So this is now my maximum number of subjects, but everything else I kept the same. So I have the same backfill rules, I have the same scenarios, I have the same design, I have the same rules for finding toxicity, I have the same stopping rules for the MTD part. I simply do not have the MED part anymore. So what that would mean is, for example, in this simulation, here, after I think I found my MTD, I would just stop and I wouldn't do this extra MED part anymore. So you can just create a second facts file for that and you can simulate that. And then what you can do is you can just create other facts files like a Boyne, where then what you do is you just create the same dose toxicity profile. So I didn't show you these, but in the CRM, I had a certain amount of dose toxicity scenarios that I was investigating, and I'm just using exactly the same ones in my Boyne. And then for Boyne, also, I make sure that the sample size is just matched. So for the CRM, I allowed a maximum of 60. So I make sure that for Boyne, that's the same. I allow a maximum of 60. I set the same target toxicity of 25%, and I have the same limits from 15% to 35%. And I try to set sort of a similar stopping rule. And then what you do is you can just simulate that and compare that. And I did that here for, say, 4 different dose toxicity relationships. And I found that with this CRM that I've really tweaked exactly how I like it, the CRM just clearly outperformed all of the other ones. And that's something that we see very often with CRMs, is that they have so many moving parts. They're not easy to design. You need to know what you're doing, or you need to spend a lot of sort of detective work going through your individual simulations to see whether the design actually does what you want it to do. But when you do that, and when you've really set it up well and made it robust in several different assumptions of the underlying truth of the dose toxicity relationship, it usually outperforms the other ones. That's at least our experience with it. And then another thing that you can do to sort of see how well the sort of this combined phase 1, phase 2A works is to just combine the dose toxicity scenarios that you have with different dose efficacy scenarios, and just make sure that in all the combination of different dose toxicity and dose efficacy relationships, it sort of picks the dose that you would expect it to pick. And the dose that you would expect it to pick, of course, differs with respect to the underlying truth. In a situation where none of the doses works, regardless of whether the doses are safe or not, if none of the doses work, what you would want the design to tell you in the end is that there is no good dose to take forward. Because why would you take forward a dose that might be safe, but it's not efficacious? The same thing is if you find that, I think this is a very academic case, but if you find that all of your doses work, then why would you take forward the MTD, which might be a way higher dose than the dose you need to take forward to achieve, say, the response rate of 20%. So but of course, you wouldn't also always then pick the dose that gives you 20% response rate if you could pick a dose that gives you 50% response rate and is still safe. So I guess the message I want to make here is that it's not always clear. So it's not so simple to say which is the dose you would want to pick and take forward. It just depends very much on the situation you're in. So let me end with some final thoughts here. If we were running this trial with this design, and then in the end we had to choose one dose to pick to go forward, I would say pick the MED. Of course, if the MED is below the MTD. And of course, only if you're happy with, say, 20% response rate, and if you would have a dose that has 30% response rate, but is still acceptably safe, then maybe you would want to pick the other one. So again, yeah, it's not so obvious. And in reality, of course, you wouldn't only use these models to guide you which dose to take forward. You would also have lots of PK, PD data, and then the decision that's being made is very much not only informed by this. And one other thing we've seen is, of course, there's a lot of advantages from a statistical and knowledge creation perspective with things like open enrollment, but it does come at increased operational complexity, and not every CRO is set up to allow this sort of real-time learning. So this is just something to keep in mind. Yeah, other things that we could have done to improve the performance of the design had we so wished is, for example, use run-ins, like small cohort run-in or accelerated titration. We could have investigated even more dose toxicity relationships or dose efficacy relationships. And we could have, I completely didn't touch on recruitment rate and how that interacts with backfill. Yeah, but I'll stop here. Thank you very much for your attention. If you have any questions, maybe there's still time now, or feel free to reach out, and I'll hand back over to Tom.
Well, thank you so much, Elias. I thought that was a really, really, really nice presentation. One question which you can help me answer is, have we published anything in a paper on this? Are we going to publish anything in a paper on this?
Good question. I don't think front fill in this sense has been published in a paper. I think backfill certainly has. There's this paper by Christine with Brolio, which I think uses backfill.
She uses enrollment. I'm not sure she uses backfill, does she?
Okay, maybe she doesn't. Maybe you're right. Maybe she doesn't even use backfill. So I don't think we have a paper on this. I mean, we've used it in trials, but that's of course behind closed doors. But yeah, we certainly had plans of publishing this. I don't know how far we are in these efforts, but it would certainly be useful to do. But I don't think I have a resource that I can point to now.
Okay. Well, once again, thank you so much, Elias. That was excellently delivered. So those of you who are still on the call, next week's we will look at simulating and what we can learn from simulation when looking at a simple phase 2 trial where we're just looking at adding in a rule for futility, or possibly if we've got a couple of arms in the trial, or maybe 3, doing arm dropping, so kind of separate individual futility for the different arms. So I hope to see some of you then. Thank you. Right. Bye, Barry.
Thank you.
Bye-bye.
Thank you very much.